Okay, I think we can start. So good afternoon, everyone. I'm glad to see many colleagues are joining. Welcome to all. My name is Gaëlle Selod, and I'm the medical director at PAHO. I'm in Washington, D.C. And on behalf of the Health and Wellbeing Unit, I'm very, very pleased to welcome you for this session on dengue, which I'm sure will be very informative to us all, myself included. So just a few words of introduction. Dengue, some of you may know, is a virus. It's transmitted by mosquitoes. It's part of a family that is called arboviruses and can be found mostly in tropical and subtropical climates worldwide. And unfortunately can cause illness and at times severe illness. And the issue that we've been observing is that the number of cases has dramatically increased over the past years and particularly affected the region of the Americas. So we felt that it would be very useful for all of us, for those living in the areas with dengue and for those traveling to those areas, to know more about the virus, to learn about the signs, the clinical signs, to know when to seek medical assistance. That's very important. What are the measures that one can take to prevent and avoid infection? And among other prevention measures, know a little bit more about the current status on dengue vaccines. So I'm very pleased to welcome 3 experts in that area. We are so lucky to have in-house experts that we can rely on. And I'm very grateful for their time and availability. So our first expert will be, and there she comes on the screen, Thais Dos Santos, our advisor on surveillance and control of arboviral diseases at PAHO. And Thais will give us a comprehensive panorama of the evolution of dengue over the years and explain what contributed to the surge. Then we have Kleber Lutz, currently international PAHO consultant. And for some of you, those of you who may not know him, I'll just introduce him a little bit more. So Dr. Kleber is a pediatrician and infectious disease specialist from Brazil with more than 20 years of experience. He's a member of several technical groups of experts on arboviruses at WHO, at PAHO, and has developed many trainings and guidelines, training programs on dengue, but not only dengue, Zika, chikungunya, and yellow fever as well, for the Ministry of Health of Brazil at PAHO. And Dr. Kleber will walk us through the more clinical aspects of dengue, and in particular, the signs to watch for. And then finally, we will have Daniel Salas Peraza, Executive Manager, Comprehensive Immunization at PAHO. And Dr. Daniel will give us the latest update on dengue vaccine. So thank you for the 3 of us, and we can get started. Thais, the floor is yours.
Thank you so much, Angel. Let me share my screen very briefly. All right. Well, thanks for hosting this important town hall meeting for dengue in the Americas. As you'll see very briefly, this year has been atypical in many ways for us. Dengue is an arbovirus, as Angel was mentioning, that comes from arthropod-borne virus, meaning that is transmitted or borne by mosquitoes. And it is a flavivirus, which is the same genus as yellow fever, West Nile, and Zika virus. All of these are closely related flaviviruses. And it has a very distinct seasonality. For us in the Americas, the period of highest transmission in the southern hemisphere is in the first semester of the year. And the period of highest transmission in the second semester is in Mesoamerica, Central America, the north of South America, and the Caribbean, and Mexico. There are 4 different dengue serotypes, and it is possible to be infected by the 4 different dengue serotypes. And I think somebody needs to mute their microphone. Once a primary infection for most people ends up being
Please mute your microphone. Thank you. You're muted, Thais.
Oh, sorry. I meant to. You didn't mean me, right? So for many people, this first infection ends up being a subclinical or with no clinical signs and symptoms. Some people do have signs and symptoms in the first infection, but it's with the secondary infection, that second infection with a different dengue serotype that is most concerning, because you have a higher likelihood of developing severe dengue. Excuse me, there we go. So the main vector in the Americas is the Aedes aegypti mosquito, although the Aedes albopictus, that is very closely related to the Aedes aegypti, is also known to transmit. But the main one is the Aedes aegypti, which is a vector that lives inside of the homes mostly. Aedes comes from the word for house, and it's widely distributed, particularly in tropical, urban, and suburban areas. Although, in areas that are not tropical, that are subtropical, it's beginning to be seen more and more. And it breeds in clean standing water. And you can see here places where the vector loves to breed. So wherever water collects and accumulates, tires, trash in the backyard, pots that are empty and that collect water, the plates under plants, you'll see that the mosquito loves to breed in those places. So the mosquito, the Aedes aegypti mosquito, will bite an infected person, and with that blood, they will pick up the virus in the blood of a person that is viremic or has virus in the blood. And then it goes in the gut of the mosquito. It has what is called an extrinsic incubation period, which lasts from 8 to 12 days. And after that period of the extrinsic incubation period, it bites a healthy human that has not been previously infected with this virus, and it transmits the disease to this new healthy person. And the person takes about 3 to 14 days before they start showing symptoms. So this is what we've seen in the Americas, and why we're here, and we're all very concerned. I know that the axis is hard to see, but basically each line in this chart refers to cases notified for the Americas of dengue. And you can see that the different peaks. There was obviously a lull in transmission in 2016 and 17. And then 2023 had been the year up until now that had broken all records in history with 4.6 million cases. But what you can see there is there's a single week in which we topped 200,000 cases in a single week. And that had been a record also in history. But what we're seeing in 2024, I don't know if you can see clearly, but that top axis is 600,000 cases. So we have had several consecutive weeks of over 600,000 cases being reported. And here are cases, but instead of giving it to you in a weekly scale, I've gone ahead and put it in a yearly scale. And we see the pattern of cases from the year 2000 until this year is clearly, steadily, and consistently increasing. But since 2010, the WHO came out with new guidance for managing dengue and identifying early predictors or early signs of severe disease called dengue warning signs. And by focusing on detecting these at the primary healthcare level and intervening early, we have been able to consistently decrease the proportion of cases of dengue that progress on to death, or the case fatality rate. And we estimate that we've been able to predict we've been able to avert over 8,000 deaths since 2011 by this strategy. So we really want to always monitor what serotypes are circulating, because as I mentioned, if there are several serotypes circulating in a single place, it increases the opportunity that a person has to be infected with more than one serotype and the likelihood that this person will develop severe disease. So this year, we have had Brazil, Costa Rica, Guatemala, Honduras, Mexico, and Panama reporting the simultaneous circulation of the 4 dengue serotypes. But I want to call your attention to the right side of the slide, where we have the circulation, where we have Argentina and Paraguay. The proportion of the different serotypes, orange is dengue 2 and blue is dengue 1, predominantly in the southern hemisphere, in the southern cone mostly. We've seen circulation of dengue 1 and 2. But when you go to Mesoamerica, including Costa Rica and Mexico, the picture looks a little bit different. And we see for the first time in many, many years, a greater circulation of dengue 3. And in addition, this year we're seeing longer seasons and we're seeing dengue in new areas where the mosquito wasn't known to thrive and the disease was then not known to happen. So this is the map of Argentina for the provinces reporting dengue in 2009 versus the last season, which 2023-2024. Similarly for Uruguay, we see dengue in 2009, no reported cases, and the departments that are now reporting cases of dengue this year. So a lot of what drives this higher transmission is outside of the health sector. So we have very little control over it from our point of view. Population growth and mobility, uncontrolled urbanization, poverty belts around major cities. We have favelas and other types of people living in conditions of vulnerability. And then also not everywhere in the region, people have ready access and consistent access to water. So you see people having to store water, which creates perfect breeding grounds for the mosquito. And we see inadequate solid waste management. There are also environmental determinants of dengue with climate change. What we see is that in warmer weather, the mosquito is able to proliferate and live longer. We see that extrinsic period of how long the virus needs to live inside of the gut of the mosquito, it shortens with warmer climates. So the mosquito is able to be more efficient in transmitting the disease. We're also seeing the vector in more places and higher altitudes, in more latitudes. And we're seeing seasons that are longer. And we are experiencing right now the ENSO, the El Nino Southern Oscillation, and there is good evidence correlating higher dengue transmission on the years that coincide with El Nino. So what can you do? What can you do in your households? Well, you can eliminate waste that collect water. The water tanks or barrels where water is stored, the mosquito tends to lay their eggs around the edge of those containers where the water touches the surface. So brushing those once a week with water and soap will effectively get rid of these mosquito eggs. Also once a week, because that is how long the egg takes to hatch. So if you're doing it once a week, you will prevent whatever eggs are laid there to hatch. You also want to change the water for flowers once a week, or the water that collects under the plates under flower pots as well. Cover trash bins and keep them dry. And containers like empty flower pots that one is saving for a flower that's to come in the future, store them upside down if they're going to be able to be rained on. For families and individuals, sick people should rest under mosquito nets. They should wear clothing that covers most of their body to avoid mosquito bites, especially when somebody in the household is already ill with the disease. And repellents containing DEET, IR 3535, or picaridin are those recommended by PAHO WHO, and they can be applied to the exposed skin or clothing in accordance with the instruction of the manufacturer. And this is really important. And also wire mesh or mosquito nets on doors and windows will keep those mosquitoes outside of your homes. And of course, you can always look for more information in paho.org/topics/dengue. And finally, before I pass on to Dr. Luce, I wanted to leave some reflections with you that dengue is really a case study for the human health impact of climate change in 2024, and it offers us a warning for the future, and it behooves us all to listen to this warning. And the region of the Americas is facing its most severe dengue epidemic in history that began in 2023 and is now continuing in 2024. And this situation is further aggravated or exacerbated by weakening of health systems and vector control programs post-COVID. A lot of these got very depleted. Climate change exacerbated poverty. And in the pandemic years, when people were practicing social distancing measures, a lot of them stayed home and the virus is taken around urban centers by people mostly because this mosquito doesn't fly very far from homes. So the case burden that we would have had from those pandemic years, we are probably seeing now because a lot of people who would have been infected didn't get infected then. And now on to Dr. Luz, and I will continue to project for you, Dr. Luz.
Thank you. And just before Dr. Luz starts, I forgot to mention that feel free to post any questions or comments that you have in the chat. Any language is fine. I think we represent with all of us the 4 languages, all of the presenters. So no problem. Ask in whatever language you're comfortable with. Dr. Luz, please. Thank you.
Hi, everyone. Thanks for the invitation to participate in this important meeting. And it's a pleasure to discuss with you something about the clinical aspects of dengue. And I think that if you work in PAHO, if you are a healthy worker, it's important to know something about the clinical manifestations of dengue, because it probably will be consulted by the other people from the community about this disease. And if you inform something wrong, it's so bad, because wrong information from a healthy worker, it's fake news. And we have a lot of fake news about the disease, especially in COVID and dengue. So it's important to know what's happened about the clinical manifestation of dengue. First of all, some initial comments about the dengue. Dengue is an acute viral disease. It means that we do not have no medication to treat this virus. It's until now. We don't know what's happened in the next decade or next 2 years about the antiviral drug for dengue. But until now, we do not have any medication to treat this virus. Second, the clinical manifestation of dengue, we say that the dengue is a dynamic disease. So someone may be sick and is well in the morning, and at the night, the patient may develop a shock and may die in the next 24 hours. So the patient can change for a good disease in the morning to a very severe disease at night. So it's important to understand what's happening with the patient. Remember that the diagnosis and management of the patient with dengue is based only in clinical manifestation and in the epidemiological data. And you have to think if the patient has any comorbidity. Why? Because if the patient has dengue and diabetes, dengue and hypertension, for example, the severity of the disease may be more difficult to treat than a people without a comorbidity. So if you treat a patient with dengue, you have to ask about the dengue symptoms, and you have to ask about the other symptoms that the patient may have because they had other comorbidity. And you have to understand the epidemiological factor. For acquired dengue, there is a comment before, you have to have a contact with the mosquito. So you have to live in a region where we found the dengue transmission, or you have to have visited an area where dengue is present. It's impossible to acquire dengue if you live in Alaska, for example. So, and dengue is a febrile disease, acute febrile disease. So you have to think in dengue in all patients who develop an acute febrile disease if this patient lives in an area where dengue is transmitted. But you have to understand more. Why? Because if the patient may acquire dengue, the patient may acquire chikungunya, and chikungunya is like a dengue, but the patient has more joint pains. If you're thinking chikungunya, you have to think in Mayaro. If you're thinking Mayaro, chikungunya, and dengue, you have to think in yellow fever. And now in Brazil, we have a lot of patients with Oropush, and the Oropush is like a dengue, but at the second week, the patient may develop central nervous system symptoms. So it's easy and difficult to understand what's happening with dengue. It's easy because dengue has cardinal symptoms, but it's difficult because dengue has the same epidemiological data of other diseases. Next slide, please. What are the clinical manifestations of dengue? Remember that dengue is a dynamic disease, so the clinical picture may change than one day for another day. The first clinical symptom is fever. All the patients with dengue has fever, and the fever is high in the first 1 to 3 days, and go down a little bit, go down, and may be present at the day 6 or 7. But during the effervescence of fever, if the patient develops other symptoms, you have to pay attention. The other symptom is the headache or retroviral pain. The headache is important clinical manifestation of dengue. And almost all the patient, 100% of the patient has myalgias and arthralgia. Myalgia is most important symptom of dengue, and arthralgia is present, but we didn't found clinical signs of inflammation in arthralgia. It's quite different from chikungunya. When we do a physical exam of patient with chikungunya, probably we will find edema in the joints. The patient may develop nausea and vomiting. If the patient develops 1 vomit a day, it's good. But if the patient develops 3 vomits in 1 hour during the effervescence of fever, it's bad. The rash is present in almost 50% of the patients. The rash is most important at the end of the disease. The patient may develop bleeding in the skin, and you call this petechia. Or if you do the tourniquet test, the tourniquet test may be positive. If you do a count of white cells, you can find leukopenia in this patient. Some patients may develop abdominal pain, and if the abdominal pain is important, this may be interpreted by warning signs. Some patients, especially the patient who has comorbidity, or if it's a small child or an older patient, may develop shock. Shock is when the blood pressures go down. And if the patients develop shock, probably this patient, if not treated according to the guides, the patient will die. Bleeding is important clinical manifestation of dengue, but it probably will be present only in the patients who develop a prolonged shock. And the patient may have any other symptom, including some symptoms like COVID. Next slide, please. So it's important to understand the clinical course of dengue. So the clinical course of dengue is divided in first phase, that is the febrile phase. There is a second phase, a critical phase, and a third phase that is the recovery phase. The first phase is a febrile phase, where the patient has a headache, fever, myalgia, and arthralgia. The majority of the patients recover at the end of the febrile phase, and the febrile phase may be present during the 3, 4 until the day 7. And the majority of the patients recover as well, nothing passed with this patient. So the temperature is high in the first 2 days because the patient has a viremia, but if the patient develops a effervescence of fever and other symptoms is present during this period, this patient may have in the critical phase. So what is critical phase? Critical phase is a phase characterized by the effervescence of fever and the warning signs that we'll discuss it after. So during the first phase, the febrile phase, caused by the fever, and why the patient, because the patient doesn't drink a lot of water, the patient may develop dehydration. And what's happened during the critical phase? During the critical phase, the patient may develop a plasma leakage. So the plasma change from the intravenous system to extravascular system. So the volume of blood diminish and the blood pressure go down. So the patient may develop a shock, and if the shock is not treated, the patient may develop a bleeding and may evolution for a death. After the critical phase, the patient began to absorb the fluid and may be in the recovery phase. What's happened in the recovery phase? If the doctor doesn't change the treatment, the patient may develop a fluid overload. So during the dengue fever, the patient may die during the critical phase or during the recovery phase. In the febrile phase, the patient has a viremia. So it's important for the diagnosis, look for the virus. So we can do the molecular test or look for NS1 to do the diagnosis. After the critical and during the recovery phase, the patient began to synthesize the IgM against the virus and IgG against the virus. What's happened with some patients is that during the second infection, the secondary infection, the antibodies that was produced during the primary infection increase the viral load and the patient may develop a severe disease. Next slide. So we have to use the case definition. The case definition is a surveillance tool for the surveillance system. It's not only for the surveillance system, but the clinician may use the case definition to facilitate the diagnosis of a patient suspect of dengue. What is a case definition of a suspected dengue case? It's a person who lives or travels in a previous 14 days to area with dengue transmission, and the patient has an acute fever. The fever is acute, the history of fever is the 2 until the 7 days, because some patients can come to the consultation without fever. So the patient may be with a fever or had a history of fever and have to have 2 or more the following clinical manifestations. Nausea or vomiting is one. Rash or exanthema, headache or retroorbital pain. If the patient has headache and retroorbital pain, it's only one clinical manifestation. Myalgia or arthralgia, petechia or tourniquet test positive, and leukopenia. The patient may have any warning signs or any sign of severity. So if the patient lives in Latin America and developing a disease like this, probably is a dengue suspected case. Remember that in child is different because the child can't explain for the doctor that they have a headache or have a renal pain. So if you do a consultation in a child and the child has only febrile disease and we ask about the symptoms, we do the physical exam, and we do not do a diagnosis of this child, this is a suspected case of dengue. So it's important to understand that any child with fever without a clinical diagnosis of the source of this infection is a suspected case of dengue. Next slide. And if the patient is a dengue suspected case, we have to stabilize the clinical classification looking for the severity. So we can classify the patients in dengue without warning signs, dengue with warning signs, and severe dengue. What is dengue without warning signs? Is that you use the case definition of dengue. But if the patient develops any of these symptoms during the effervescence of fever, is a dengue with warning signs. The most frequently and most important sign is the abdominal pain or a tenderness of the abdomen. So it's important to look for the abdomen, do the physical exam in the patient to look for tenderness. If the patient has a persistent vomiting, like three vomiting episodes in 1 hour or 4 vomiting episodes in 6 hours. So it's impossible for this patient to be hydrated. So it's a warning sign. If you look for the patient and found pleural effusion or fluid accumulation like ascites, it's a warning sign. If the patient develop a mucosal bleeding, if the patient has a lethargy, or if the patient develop postural hypotension. So you have to measure the blood pressure in the seat, and please wake up and we measure the blood again. So if the patient develop postural hypotension, it's a warning sign. In child, it's important to look for the liver, and if you found a liver enlargement 2 centimeters or more, it's a warning sign. If the patient develop an increase in hematocrit, it's warning signs. So it's quite different to treat the patient without warning signs and patient with warning signs. But if the patient go to the hospital or the primary care and is in shock, or if the patient has a respiratory distress due a severe plasma leakage, or if the patient has a severe bleeding, like stomach bleeding, intestinal bleeding, it's a severe case. Or sometimes the patient may have an severe organ involvement, like a liver damage, a myocarditis, etc. So this is a severe dengue. So it's important to classify the severity of dengue using this table. Next slide. So the diagnosis of dengue is based in epidemiological and clinical data. Only use this for the diagnosis of dengue. But if possible, there are some places that we can do lab tests for the patient. In the majority of places in Latin America, we can't do this. We use only clinical and epidemiological data. So for treating this patient, we use only this. But if you can do any lab test, you can use NES1. NES1 is a protein that is produced by the viral replication, and you can use this for diagnosis. It's important that if you use a rapid test for detecting NS1, it's not useful for the lab diagnosis of dengue. So you have to use the ELISA for detection of NS1. But it's important to use RT-PCR or a molecular test for dengue lab diagnosis. Why? Because the majority of the labs use a trioplex so you can detect dengue, Zika, and chikungunya. You have to use NS1 or RT-PCR for dengue diagnosis in the first 5 days of treatment. If the patient is in the day 6 or more, you have to use the serology, IgG and IgM. But sometimes we have not a good response looking for the IgM. Some patients with Zika has IgM positive for dengue. Some patients of dengue have the IgM positive for Zika. So they're a little bit confused to do the correct interpretation of serology. So it's important to use molecular tests or NS1 detection for the diagnosis. And of course, if the patient die with dengue, we can do the tests in some fragment of liver, the heart, etc., and do immunohistochemistry to detection the viral particles in the tissue. Next slide. And what's happened about the treatment? It's important to do a good anamnesis. What is anamnesis? Anamnesis, what's happened with the patient? When the fever began? What's happened? Fever, myalgia, arthralgia, vomiting, abdominal pain. It's important to understand what's happened with the patients to do a good clinical diagnosis. It's important to check the vital signs because if the pulse, the respiratory rate, the blood pressure, and the temperature is okay, probably the patient is good. But if the patient has a tachycardia, probably this patient is beginning a shock, especially if the patient is a child. Even in the absence of fever, you have to measure the temperature because some patients develop a temperature about 35 centigrade grades. So it's important to look for hypothermia that the patient may develop. And it's important to look for the plasma leakage and the capillary refill. The time of the capillary refill is essential. So never treat a patient with dengue without abdominal palpation. It's important to put the patient in a bed and do the abdominal palpation to look for any pain. It's important to check the capillary refill and always look for warning signs, vomiting, abdominal pain, etc. It's important because we have to distinguish between dengue without warning signs and dengue with warning signs. So the treatment is bed rest. All the patients have to bed rest. We have to treat the fever with paracetamol, and a lot of places in Latin America use metronidazole. It's the same. You can use one of this drug. It's important to use oral fluids. The patient with dengue have to drink a lot of fluids and always look for warning signs. And inform the patient if the patient develops warning signs, they have to come back to the hospital. And you have to use the intervention, group A, B1, B2, or C. Group A is the patient without warning signs. So this patient may be treated at home only with oral fluids. The group B1 is the group as a pregnant woman, is a patient that lives far from the hospital, or elderly patient, or a child under 1 year of age. This patient may be transferred to the hospital. They have to use oral or IV fluids. If the patient has any warning signs, this patient have to receive the treatment at the hospital and you have to use IV fluids. And if the patient is group C, so if the patient is in shock or have a respiratory distress, this patient have to be treated in the hospital in intensive care unit and use a lot of IV fluids during the 24 hours for 48 hours. Next slide. So it's important to understand who needs to be hospitalized. So all dengue with warning signs, dengue with criteria for severe disease. If the patient has oral intolerance, difficulty of breathing, narrow of pulse pressure, arterial hypertension, acute renal failure, prolonged capillary refill, all the pregnancy women, especially in the third trimester, and if the patient develops coagulopathy. So all these patients have to go to the hospital, admitted in the hospital, some of this admitted in intensive care unit. It's important to inform the population about this. Next slide. Okay, this is all that I have commented, and I'm waiting for questions. Thank you.
Thank you very much, Dr. Luz. So if I put myself in the feet of someone who may not be knowledgeable or, a medical professional, I think your slide about the warning signs, that you can observe in your family members or yourself is this, while the fever drops, the abdominal pain, the vomiting that is not stopping, potential bleeding from the mucus, the mouth, the nose, and the hypotension. So I think those are the signs really that should alert oneself to really seek medical assistance. I always encourage everyone to seek medical assistance for, for any infection, but really, this is really the time where one should not wait. Thank you very much. So now we can move to the vaccination part with Dr. Daniel. I think you can share your screen. Thank you.
Yeah, thank you, and go. Okay.
Perfect. So we can see it.
Okay. Thank you. So we're going to be sharing some remarks, some of the main aspects to consider about the current dengue vaccine, the Qdenga vaccine, or Takeda 003, known with that name during the trials. So we're going to start talking about the phase 3 trial that is the study that generated all the recommendations that we have up to this point, or the main recommendations. So we can say that this vaccine, the Takeda 003, showed efficacy in preventing dengue disease for all the dengue serotypes in patients with a previous history of dengue infection. That is known as seropositive. The thing or the consideration that should call our attention is in previously uninfected patients, the seronegative, the vaccine showed efficacy specifically for serotypes 1 and 2, and the efficacy is high for type 2 than for type 1. Probably for type 2 is the highest one and is moderate for serotypes 1. But unfortunately, it did not show efficacy in preventing disease or hospitalization for serotypes 3 and 4. And not just that, there is a risk of enhanced disease by serotypes 3 and 4 in seronegative vaccinated children. This cannot be ruled out. And this isn't in people with no history of dengue at the time of vaccination. There could be a higher risk of severe disease and subsequent infections by serotypes 3 and 4. And this is because this vaccine is a live attenuated vaccine. What does it mean? When we talk about vaccines, there are different types of vaccines, the different, we could say the different platforms where those vaccines are developed. And in this case, this is a live attenuated. It means that it contains the virus, the dengue virus, but they have looked to diminish the power to cause disease in these viruses. But, and as Thais was explaining, when you have a previous infection of dengue, of any kind of the 4 serotypes of dengue, if you get infected again with a different serotype, then the risk of having a severe disease is increased. And it turns out that for serotypes 3 and 4, when a person that never has had dengue in its life, and then it receives the vaccine, it completes the schedule. And after that, 1 year later or more, probably one more 6 months or more, that person get infected with serotypes 3 and 4, the vaccine may work as a primary infection. Then this is not known. I mean, the risk is under the current data that we are in power of, there is no data about how much is this risk of having an enhanced disease, a severe disease, for the people that received the vaccine when they had no history of dengue, and that those persons are going to get infected later, 6 months or later of receiving the vaccine. So this is important to know, because of course there are risks. We need to understand what is going on. The study didn't show any results that could let us know if how is this possibility in terms of numbers. So this is probably something complicated to understand for most people, but this is just to confirm that this vaccine can serve 2 purposes. The first one is to prevent a case of dengue, the infection, I mean, not the complications, but just the infection. And in that sense, the overall vaccine efficacy is 61.2%, considering the seronegatives and the seropositives, the people that were already exposed somehow to dengue, the seropositives, and the people that were never exposed to dengue. And as you may see, we are going to look into the confidence interval. The confidence interval is in between parentheses, and this indicates how confident is the level of efficacy that we are going to see in the central value, which is the one in bold. So you see that for virologically confirmed dengue, we have a 61% of overall efficacy using this vaccine. But when we see the division between seropositives and seronegatives, you're going to see that for seropositives, the percentage is higher than for seronegatives. It means that the vaccine works better for the people that were already exposed to dengue than the ones that were never exposed. And when we proceed with the breakdown of the different serotypes of dengue, you can see the efficacy varies among the different serotypes. And you see that for dengue 2, the percentage is the highest, and the confidence interval is a pretty decent interval, which probably shows that the 80% that we are seeing in the level of preventing the virologically confirmed dengue for dengue 2, in the case of seropositives, is probably that. It's very close to 80%. When we look into the value for dengue 1, you see that it's 56% approximately. And the level of confidence is, I mean, it's wider, but it's close to that 56%. But when we look into the values for dengue 3 and dengue 4, the values for dengue 4, it seems pretty decent. I mean, it's 70%. But when you see the confidence interval, the values in the parentheses, they are very wide. So it means that the statistically level of confidence that you're going to get protection against dengue 4 if you have already had in your life at least one confirmed infection by dengue is going to vary a lot. I mean, that 70% is not that firm that we had with the dengue 2 and dengue 1. And when you see the dengue 3, the level of protection is 50% with wide intervals. And when we look into the right hand of the screen, you're going to see into the seronegatives. And then the level of protection of efficacy to prevent the confirmed dengue is going to be approximately 50%. But the problem is with dengue 3 and 4, with the people that were never infected with dengue, you see that we have negative values. And that value actually is telling us, oh, there is a risk that you're going to get an enhanced disease if you receive the vaccination with this dengue vaccine and you have never been exposed to dengue before. And the other outcome that this vaccine can't work in is the hospitalization. And for hospitalization, usually the overall vaccine efficacy is higher than for preventing the infection, is 84%. It means the vaccine seems to work better to prevent severe cases, the hospitalization, than to prevent the just infection. And we are going to see again, there is a difference, probably is not that high between the seropositives and the seronegatives in terms of the overall vaccine efficacy. It's higher for the seropositives, 85% or 86% versus 79% for seronegatives. And you see the values there. I'm not going to go into detail because this is very technical, but this is just for you to know that this vaccine is unbalanced. It is not going to protect the same level of, it is not going to give the same level of protection against the 4 serotypes, against hospitalization, and against the confirmed dengue. So, and you see again the negative values, which means this vaccine could serve as a primary infection for the ones that were never exposed to dengue and received this vaccine, and then subsequently are going to be infected with the any other type of dengue, or mainly the dengue 3 and 4. So we have the recommendations given by SAGE and the PAHOS-TAC, our technical advisory group on vaccine preventable diseases. That is our PAHOS reference advisory group, which gives the recommendation to the director, and then the director transmits or adapts those recommendations to the countries. And SAGE, which is the maximum level of, or the group that is led by WHO and is like the worldwide reference group of that gives recommendations about introductions of vaccines. And with you see that I try to divide the different criteria that were given by those different groups in different but close dates. And you see the level of transmission, they recommend the same. You should use this vaccine if you live in a country with a high, I mean, they are not given the recommendation individually, first of all. This is a recommendation for the whole country, okay? But then they recommend that a country should decide to go for the introduction of the vaccine if they have a high disease burden and high intensity of transmission. And the PAHOS-TAC reflected and decided to endorse that the level of recommendation. But there is an important thing to note, and it is that there is no regional standard to determine what these high disease burden and high transmission intensity settings are. So, of course, a country can say, see, we have, I mean, this year's been very, very heavy in terms of the peak incidence. We surpass the highest level that we had in the previous years. But the thing is that there is no standard. So, I mean, and if you see these vaccine is recommended to be incorporated or included in the vaccination schedule if even 1 to 2 years before the peak for hospitalizations. So, I mean, if you consider that, if a country is having a big outbreak of dengue, they are late. If they are already having that and they are already having the hospitalizations, it is already late to decide to go for this vaccine. And it is recommended from 6 to 16 years of age. And in the case of PAHOS-TAC, this was adapted, and the PAHOS-TAC decided, and the director decided to recommend it because there were these kind of not enough data to define the safety profile of this vaccine. So the PAHOS-TAC decided that this should be done under a pilot test as part of a phase 4 trial, okay? Which of course is going to give you a lot more control about the variables, about the safety measures, about the probably cause and effect of all of what can be assessed during the implementation of this vaccine. For the communication strategy, there is a consensus that there should be a communication strategy on place, and with community participation, probably PAHOS-TAC went a little bit beyond and said that this communication strategy should allow communities and health professionals to be fully involved and informed of the potential benefits and risks. And for the SAVI surveillance, the SAGE didn't refer specifically for these, and we're going to talk about the position paper that came lately, or recently, but the PAHOS-TAC said that every country that decides to add this vaccine to their schedule, they should strengthen the SAVI surveillance. The SAVI is the possible adverse events that could be related to the vaccination. And so a controlled study, the SAGE said, no, you should go for it if you have high disease burden, high transmission. But the PAHOS-TAC said, yes, you should really look into your the possibility of having these control study. And the other considerations, the PAHOS-TAC referred that countries should have an adequate vaccination service for adolescents, because as you may see, the main target population for this vaccine is from 6 to 16. And of course, that is going to be focused on the high schools and probably like middle schools and some elementary. But this is something that is trying to, the PAHOS is trying to remark in terms of a country should not go for this if they don't have like these kind of agreements between the education sector, or they have not vaccinated, for example, HPV, that you know, the HPV vaccine, human papillomavirus, is applied during the adolescence. So that's something important to note. So on May 3rd this year, the WHO position paper on dengue vaccines was published, and then they considered in this position paper some other things that I'm going to mention here, and it is that people living with comorbidities should be considered, could be considered to be vaccinated as well, and this widens the interval of age that. Remember that in the first instance, it went from 6 to 16, and now they're saying that even though the main target still is 6 to 16, people, especially with comorbidities, and especially with sickle cell anemia, diabetes, hypertension, or some other underlying comorbidities that may result in bleeding tendencies, or, for example, ulcerative colitis, it should be considered to receive this vaccination. They also considered to extend the possibility for travelers from 6 to 60 years, and they updated the contraindications, and they said that because there is not enough data for pregnant women and lactating women and immunocompromised persons, and you know, this vaccine should not be given to those, and if there has been an specific anaphylactic reaction to this vaccine or to the components of this vaccine, this should be a contraindication. During the first dose, you had an anaphylactic reaction, then you should not necessarily go for the second shot, because at the end, and I forgot to mention, you see in green that this vaccine requires 2 doses to be completed the schedule with a 3 months interval. It should not be less than 3 months, and if you didn't receive the second dose, you should receive it as earlier as possible. But it doesn't mean that you need to restart if, for example, if there's been 5 months between a dose, it doesn't mean that you need to restart the schedule. You can receive the second dose at 6 months or 1 year later, and the studies are not enough in terms of the length to confirm how long is the level of protection. So there is not yet a recommendation about booster doses after, for example, 5 years or after 2 years. It seems like after 5 years, the level of protection starts to wane. So, but there is no conclusive information about boosters, and of course we need to understand more what is the thing that is going to happen with the possibility of the enhanced disease due to vaccination. Other considerations for example, the Imperial College of London identified that the impact of this vaccine would be modest over a 10-year period after its introduction. And it says that if you cover 80% of, you know, the target population, and you're going to get the benefit of preventing approximately 50% of infections and 20% of the hospitalizations. So that's something important to consider, that as you see, this is not a monster slayer. It's not a vaccine that is going to change dramatically the course of any epidemic. So you need to give time, because it's not mainly targeted to the general population, and because it is unbalanced, as you saw, it is not protecting the same for all the levels for all the serotypes at the same time, and even there's risk for some of them. And it's important to know that the dengue 3 and 4 I mean, it's are circulating importantly in our region. So that's another important consideration for people that decides to go for this vaccine. And also a very limited vaccine supply is expected for a short and medium term because of the production. And for this year, actually, it has been very limited, the availability. Therefore, vaccination against dengue is not expected to have an impact on the epidemiological behavior. Just to mention 2 slides more, so we have the clear risks and some of the gaps in knowledge, and you see that potential significant risks is the anaphylaxis, including anaphylactic shock. This was not evident during the phase 3 trial, but it turns out that during the introduction that Brazil recently did with this vaccine, an important number of people, I mean, it's not, of course, most of people, but an important number has been experiencing anaphylactic reactions. You know, anaphylactic reactions are those, there are kind of an allergic reaction, but at a higher level that can really put into, you know, in danger your life. So that's important to consider, and we're going to mention the numbers after this slide. The severe dengue due to reduced protection over time, and severe dengue or dengue hospitalization with serotypes 3 and 4 in seronegative individuals. And some of the risk information gaps is the safety profile for inadvertent use in pregnancy or lactation, the immunocompromised reactivation to virulence. I mean, the people that can have a HIV or any kind of cancer or treatment with steroids, chronic use of steroids, you know, this can actually be have a higher risk of complication because you're actually given a live virus, which is attenuated. Yes, it doesn't have the potential for most of people to produce a disease, but for some people that you know their immunity system is not able to defend as strong as for other people, this could turns out in a way that we are not intended to. And there's not enough information to concomitant use with other vaccines, and the thing that I was referring to, booster dose. So you see in Brazil, this is the latest data. They decided to go public with this vaccine. They have applied more than 1 million doses at this time, but at May the 3rd, they were probably like in the 700,000 doses applied. And you see that they reported a total of hypersensibility reactions of 287, which had incidence of 20.4 per 100,000 doses. And you see the anaphylaxis. The anaphylaxis, they reported 46%. No death. Fortunately, there were no death cases, but they needed, you know, to use adrenaline. And the thing is that some of them, not all of them, but some of them needed to, you know, receive the adrenaline shot. And the thing is that this percentage of 30, or not the percentage, the number indicator, the 32.7 per 1 million doses is higher, way higher than we see for the rest of the vaccines, which is normally from 1.9 to 0.9 to 1.8 cases per million doses. So it's an important rate of anaphylaxis. It hasn't caused the program to stop. Actually, what Brazil did is to give the vaccine just in places where they have the people prepared, trained to give attention to any kind of anaphylactic reaction, and they modify the guidelines so that if a people vaccinated previously should be under observation for 15 minutes, and in case of a history of previous anaphylactic reactions due to other causes, the observation period goes until 30 minutes. And of course, to guarantee a timely diagnosis and treatment of anaphylaxis at the vaccination site. And this is the last slide. So this is not a balanced vaccine. It has its limitations. Of course, it is, we could say, better than having nothing, but of course it has risks. And those risks are in case of the anaphylactic reactions for the immediate term, And for after 6 months of being applied, this risk of having an enhanced disease is not totally, conclusive. What is the number of this risk in terms of the possibilities? But it is there, and we are going to understand a lot more about how it's going to present this enhanced disease and what are going to be the numbers of the possibility of having that enhanced disease. Thank you.
Thank you very much, Daniel. Again, a very rich and comprehensive presentation. I must say the data that you presented is quite sobering. I think it's the first time that I see in the vaccine efficacy negative percentages. Typically, you see 80, 50 going down to maybe 20, 10, but never negative percentages for. And I understand this is for seronegative population exposed to serotype 3 and 4 with this vaccine. Okay, we still have some minutes for the questions. And for those of you who cannot, who need to leave, the session is being recorded, so you can consult that later on. We will have Evelyn, our communication focal point, running through the questions. But I would like to start with one for you, Daniel. Just a comment first. To my knowledge, this dengue Takeda vaccine is the second one that is being made available in several countries. Correct me if I'm wrong, but my understanding is that the previous vaccine, the Dengvaxia, is now being discontinued probably worldwide. Yeah. And the Takeda vaccine, so the current one that you presented, is not available in the US, to my knowledge, right?
Right.
And which brings me to a question, isn't that contradictory with all the safety concerns that you have presented and the availability or the recommendations to have the possibility to vaccinate in countries where there is a high level of endemicity? So you assume that the person has been exposed, so is, will not develop this potential enhanced reaction. What I am not sure I understand is why are there any countries that are not typically endemic for dengue, like the UK, like several countries in the European region? Why have those countries approved the vaccine? That's maybe a complex question, but I would like to start with that, if you don't mind. Thank you.
Yeah. Well, that recommendation would be more for the people that are traveling abroad and then can visit endemic countries so that they could have a certain level of protection. But of course, for those people, if they have subsequent visits where like regular traveling, there could be these probability of having an enhanced disease for dengue 3 and 4 in a subsequent trip. And yes, there was a previous vaccine that is not any longer in the market. It was the Dengvaxia, but it actually some of these enhanced disease or the severe disease due to this vaccine were, a topic of major concern for many people, even though at the end it was supposed that in the balance, the benefits could be even higher, but they decided and then people didn't continue using it. And so they withdraw the vaccine. Yeah.
Thank you. Evelyn?
Thank you, Gael. Thank you to those participants who send us the questions in advance. I will start with the question that sent Patricia Torres. That is a question in Spanish. ¿Qué recomendaciones específicas pueden dar en cuanto al uso de repelentes y dispositivos personales y ambientales para evitar las picaduras de mosquitos? ¿Cuáles son los más recomendables considerando precio y efectividad? Mil gracias. Doctor Luz, por favor. Doctor, tiene su micrófono cerrado.
And maybe.
Adelante.
Why don't I go ahead and take that? Você quer discutir
Gracias,
repelentes? Melhor eu... Tá, obrigada.
Gracias.
Entonces, como medidas adicionales, las personas pueden, como yo mencioné, usar ropa de manga larga. Yo vi que hay otra pregunta sobre la efectividad de eso. Ninguno de los métodos que damos de protección personal son 100% efectivos, pero al usar una combinación de estos, uno minimiza su riesgo. Entonces, el usar mangas largas, el usar repelentes que sean DIT, picaridina y IR3535 son los que la OMS recomienda porque ha verificado su efectividad. El uso de emanadores o estos productos que se usan para ambientes no ha sido evaluado, la efectividad no ha sido evaluada. Entonces no se recomienda. No quiere decir que su uso sea perjudicial, solo que no se ha verificado su efectividad. Cambio.
Muchas gracias. La siguiente pregunta es sobre la vacuna de dengue. Si uno ha tenido dengue en una ocasión pasada y no se ha puesto ninguna vacuna, ¿es cierto que si a uno le vuelve a dar sería muy grave? Doctor Salas, por favor.
Sí, como vimos, más bien el riesgo de tener una enfermedad empeorada o potenciada por dengue sería más alto para las personas que no han tenido dengue nunca. Las que ya han tenido, pues depende también de qué tipo de dengue hayan tenido y la posibilidad de que esto pues vaya a reflejarse en una enhanced disease o una enfermedad potenciada. También va a depender mucho del serotipo, pero en general, digamos que es más segura, se podría decir, para las personas más bien que ya han tenido dengue previamente que para las que no. Y siempre recordar que el riesgo en realidad que se ha visto más posible de tener una enfermedad potenciada por dengue o una enfermedad grave por dengue secundario a la vacuna sería más si se infecta por el dengue 3 y 4, ¿verdad? Porque también hay que tener en cuenta que no es que hay un riesgo potencial evidenciado hasta el momento de si la persona se enferma con dengue 1 y 2, que posiblemente es lo que hablamos, como la protección es más fuerte para estos dos subtipos, y recordemos que la inmunología del dengue funciona justamente protegiendo contra la enfermedad o la que usted se enfermó, el serotipo que usted se enfermó, la inmunidad va a durar posiblemente de por vida, pero para los demás se desvanece y más bien después queda con esa sobrereacción posible del sistema inmunológico contra esos tipos. Entonces la vacuna funciona un poco parecido en ese sentido. Y Thais creo que quiere complementar algo también.
Sí, porque me parece que aquí hay dos cosas, ¿no? El beneficio es mejor de la vacuna para la persona que ha tenido una infección previa, pero la persona que tuvo una primera infección y tiene una segunda infección, su riesgo a desarrollar es más alto. Y los estudios tienen un rango alto de si es 2 veces o 4 veces más alto el riesgo de desarrollar enfermedad grave. Pero son dos cosas y que pueden parecer confusas. Es decir, la vacuna es mejor para quien ha tenido una infección primaria, pero esa persona con una infección primaria tiene mayor riesgo a desarrollar. Entonces, solo para
Exactamente.
separar los dos temas, ¿no? No
O
es
sea,
que...
más bien el asunto aquí, Thais, es si la vacuna es culpable de provocar una enfermedad posterior grave
Exacto.
o no, porque al final el riesgo con vacuna no sabemos cuál es, pero es potencial y puede provocar una enfermedad grave posteriormente. Igual, cuando una persona se infecta, no pongamos a la vacuna de por medio, lo que ya explicó Thais, si se infecta con un serotipo de dengue y después recibe una infección o otro mosquito lo pica y le transmitió otro serotipo diferente después de 6 meses, el riesgo también está ahí de que tenga una enfermedad, ¿verdad?, grave por dengue. Entonces, el asunto aquí es si la vacuna eventualmente va a servir como esa primera infección, que entonces obviamente eso es lo que no quisiéramos, porque obviamente uno no quiere hacer daño. O sea, las intervenciones en salud siempre son para tratar de no hacer daño, pero en realidad podría ser que el riesgo sea muy bajo, no lo sabemos, pero hasta que no tengamos más datos, no podemos saber exactamente dónde estamos en ese sentido. Y Brasil posiblemente ya va a empezar a tener, si esto va a ocurrir en cuestión de, empezó en enero, ¿verdad, Thais? La vacunación allá en Brasil, entonces posiblemente estamos exactamente en el tiempo en que vamos a empezar a ver si es alguno de esos enfermedades graves secundarias a la vacuna, si es que se presentan, a ver qué frecuencia.
Muchas gracias, doctor Itais. La siguiente pregunta es de Norma. ¿El aumento dramático de casos de dengue tiene algo que ver con que los países están o tienen más acceso a pruebas de dengue? Thais, ¿quieres responder
Sí.
esta, por favor?
Sí. Nosotros, la mayoría de los países nos notifican casos sospechosos. Es decir, si cumple la definición de caso que mencionó Clever, el sistema de vigilancia lo recoge y lo notifica y nosotros así lo contamos. Si los 8 millones y y mucho, casi 9 millones de casos que tenemos son casos sospechosos, confirmados y sospechosos. Entonces, no hay duda de que se han mejorado los sistemas del diagnóstico laboratorial post-COVID. Y tenemos más o menos un 50-45% de esos casos sospechosos tienen confirmación de laboratorio. Y también, además, por grandes logros que se tuvieron durante COVID, se pueden secuenciar esos virus para ver si hay algo diferente del virus y no hay ninguna señal de que el virus sea diferente este año comparado con años anteriores. Pero este aumento no es porque tenemos mejor capacidad de laboratorio, porque nosotros lo que siempre monitoreamos es el caso sospechoso que no requiere un diagnóstico de laboratorio. Cambio.
Muchas gracias. Las siguientes preguntas son de Julio. La primera es, ¿hay alguna gráfica que extrapole los casos de dengue con los problemas de manejo de agua y desechos en cada uno de los países de la región de las Américas? Y la segunda es, ¿cuál es la relación de casos con respecto a género y etnia? Me parece que también es para ti, Thais.
Sí, a nosotros nos encantaría tener este tipo de gráfico, pero normalmente los ministerios de salud no disponibilizan este tipo de datos, ¿no? Y si lo conseguimos, otro problema es que las áreas de salud que utiliza el Ministerio de Salud no siempre son las mismas áreas que utilizan otros ministerios para otros propósitos. Entonces, el poner todo sobre un mapa queda un poco complejo y difícil. Nosotros estamos pues trabajando con los países en cómo nosotros integramos los diferentes subsistemas de información del país para generar gráficos mejor informados, para que realmente los países puedan ver las áreas de mayor riesgo y especialmente en estos momentos de vacas flacas, priorizar intervenciones a donde más se necesiten, donde haya mayor vulnerabilidad. Pero no estamos ahí todavía, esto es un work in progress, ¿no? Un trabajo en progreso, como se dice en inglés, y ya llegaremos hasta allá. Pero muy necesario este tipo de análisis. Con relación a lo segundo, los países no siempre proporcionan información sobre etnia, grupo étnico, pero sobre género sí. Y vemos en la mayoría de los casos, siempre vemos una pequeña predominancia de las mujeres. Y esto puede ser por varias cosas. Una de las razones es que tiende a ser un mosquito intradomiciliario, entonces puede ser que afecte más a mujeres y a hombres, pero también las mujeres tienen patrones diferentes documentados en diferentes países de buscar la atención en salud un poco de manera más proactiva que los hombres. Entonces, esta leve diferencia entre los géneros se puede dar por eso. Cambio.
Gracias. Las siguientes preguntas son de Tiago. ¿Contra qué serotipos protegen las vacunas actualmente disponibles? ¿Existen estudios de protección vacunal con datos poblacionales que no procedan de ensayos? Doctor Salas, adelante.
You're muted.
Doctor, tiene cerrado el micrófono.
Gracias. Bueno, creo que en la presentación quedó muy claro de que es una vacuna no balanceada, que tiene una protección mayor sobre todo con el serotipo 2, un poco menor con el 1, y para el 3 y 4 varía ahí y sobre todo el riesgo más bien, o sea, puede ser más bien baja la protección que confiere y el asunto más bien es el riesgo de tener una enfermedad potenciada por la misma vacuna. Entonces, eso es lo que hay y son de fase 3, o sea, los resultados que tenemos al momento de eficacia son de fase 3. Cuando ya vamos a nivel poblacional, hablamos ya de efectividad y en realidad ahí vamos a ver qué es lo que ocurre con Brasil, porque justamente Brasil es el país que es el único, bueno, Argentina también está vacunando, pero no al nivel, los números, las cifras que yo les acabo de decir, de 1 millón de dosis aplicadas, ningún país en el mundo lleva ese número de vacunas de dengue, de esta taqueda 003 o la vacuna actual. Entonces, los datos poblacionales los vamos a empezar a ver justamente en el siguiente año posiblemente, donde ya tengamos. Y también Brasil, además de haber introducido la vacuna en el sistema público, en los dorados creo que está haciendo también un estudio fase 4 ya controlado, en donde pues pretenden tener justamente ya este tipo de números, pero no solamente de un estudio poblacional, sino de una población más grande que lo que se hizo en el Phase 3 Trial, pero ya con datos un poco más controlados también, ¿verdad? De cuánto es la eficacia a nivel poblacional.
Muchas gracias. La siguiente es de Federica. Are there plans to equip governments with larvicide to distribute to the population and use in public places? Thais. Would you like to respond to this question?
Sure. Thank you. So as I mentioned before, personal protective measures include, the wearing the long clothes, the repellents, etc. And these also include the measures that I spoke of in my presentation, like eliminating breeding sites in and around the homes, making sure you don't have containers that are accumulating water, having those mosquito nets in the household. But the use of larvicides as such, especially the chemical ones, they really have to be used by experts that know how to manage these chemicals. So it's not recommended for them to be used by the general population at large. They have to really be used by trained professionals. Over.
Thank you, Thais. And I will take the next question, which is in French from Cynthia, and I translate it. So Cynthia mentions that from her experience, and the common recommendation is to wear, long sleeves, pants to avoid the bites of the mosquitoes, which in this case, the mosquito bites during the day. So it's important to be fully, to make sure to have those outfits during the day. But from her experience, she's noticed that the mosquitoes tend to bite through the fabric. Was there a change in the behavior of the mosquitoes that you've observed, that they've found strategies to overcome this hurdle? That's one. And two, among the mosquito repellents, are they toxic components that one should watch for? Thank you.
The first question is regarding that. I've seen that happen as well, and that's why I was mentioning the importance of layering different protective measures. Maybe it's the repellent in addition to the long sleeves, and something that I didn't mention during the presentation that I meant to, the mosquitoes, they adapt. And if the female mosquito is the one that bites and that she needs that blood meal to lay her eggs, if she's hungry enough, she will bite in many times of the day, but they're generally day biters with the highest activity at dusk and at dawn. So these are times that, maybe you don't go outside where you could be exposed to mosquitoes, or if you keep your house mosquito free, you stay inside, etc. But there are no studies that we know of that look at their behavior, or whether there has been a change in their behavior or an enhancement in their aggression, if you will. The second question was about, remind me?
Potential toxicity of the components of the repellents.
Yeah, the repellents that include the 3 active ingredients I mentioned before, the DEET, the IR3535, and the picaridin, they're generally safe, and their effectiveness has been well evaluated. DEET particularly has been the most studied repellent in history. So there's a lot of information there. Sometimes what you'll find with DEET is that it may eat through some plastic. So, sunglasses or flip-flops or whatnot, but so, you might choose picaridin for that reason or whatnot, but all 3 are considered effective as assessed by the WHO.
Thank you, Thais. And just because we have very little time remaining, I'm seeing that Federica's next question was already, abundantly answered by Daniel throughout his presentation. And the question was, is the dengue vaccine considered effective? And then we go down to Norma's question. Are there any statistics on vaccine efficacy on immunocompromised individuals? Danielle, you want to take that one? You're muted.
Sorry, no, there is now statistics about that still.
Okay, thank you. Evelyn, do you want to?
But I mean, because of remember that is a live attenuated vaccine, and it is an important risk to apply this vaccine to a immunocompromised person. So that's something that probably with live attenuated vaccines is a contraindication. So that's something that is not probably, we're not going to test the risk to see if a person is going to develop a severe disease by dengue with an immunocompromised situation.
Understood. Let's take the next one. Evelyn?
Okay, the next one is, if someone contracted dengue previously but doesn't know what was the type, can we still recommend this vaccine? What's the danger for people older than 16 or aged people who is otherwise healthy in taking this vaccine?
Okay, I'm going to
Dr.
start
Salazar.
I'm going to start with the second question. And as you saw, the position paper by WHO is actually recommending that mostly for people that have comorbidities like bleeding disorders, this could be really considered for those people even until the age of 60. Okay, so you can use this vaccine in older groups. And actually, Brazil and Anvisa, the regulatory agency, approved the application of this vaccine until the age of 60. So in the private sector, we have this wider interval of people that are receiving the vaccine. So it can be used, actually. But of course, it is going to be of higher benefit probably for the people that have comorbidities like bleeding disorders. And if someone contracted dengue previously but doesn't know what was the type, I mean, you saw that the level of protection, of course, it is major, or it is most important for type 2 and type 1. The thing is that, I mean, of course, it is very difficult to know if a person, if it is not in the acute phase, of course, you can have a seroprevalence test, but the thing is that the quality of these tests are not equal, and the predictivity level, I mean, how these tests can really say if you were previously exposed to dengue can vary depending on the type of test and the prevalence or the incidence of dengue. So that's something that, I mean, it's unpractical to use when you are vaccinated in a public, setting, in a mass setting. But individually, I mean, you can still try to see if you had previous dengue. But the thing is that, I mean, it's not something practical. So if a person doesn't know the type, you can still use this vaccine. But the thing is that, of course, I mean, if you already had dengue 1 or dengue 2, receiving this vaccine is not going to confer a major benefit, because the benefit is mainly for 2 and 1. So if you were already infected with these dengues, you're not going to receive that, like the real benefit of the vaccine. I don't know if I made it too complicated, but those are not probably easy to answer questions sometimes.
Thank you, Dr. Salas. The next one is from Federica. What if a person was vaccinated with Dengue before moving to a high-risk area and is unaware if he or she is a seropositive or seronegative? Is there a chance to find out the serology and if the vaccine would count as a first infection?
Well, that's what I was referring in the previous question. I mean, it depends on the test. Not all the seropositive or sero condition tests are the same quality or bring the same level of confidence. I know that probably the ones that brings higher level of confidence are like most difficult to get in most of the settings in our countries and are more expensive. So that's something that, I mean, you can do the test, but of course it's not like the ideal situation. That's why it is recommended actually for a country with high burden of disease, because for the individual use, you can use it, and it doesn't matter unless you have a history of anaphylactic reactions or any kind of immunologic condition that can really reactivate your system to have an enhanced disease. It depends on that, but it's not really clear the benefit. And if even SAGE and PAHO RITAC is not recommended to proceed with this kind of zero condition test previous to the vaccination, because it's not practical.
Thank you. I think, creo que las dos próximas preguntas están relacionadas. Ante el escenario descrito, ¿cuál será la posición de nuestra organización para la vacunación contra dengue para el personal en nuestras oficinas de representación de zonas con mayor incidencia? Y si está contemplada la entrada de la vacuna al resto de países endémicos de Sudamérica.
Bueno, es una buena pregunta. Para Sudamérica, les voy a decir que la vacuna está disponible por fondo rotatorio. Esta vacuna está disponible en una cantidad muy limitada para este año. Creo que Perú y Honduras ya pidieron vacuna, también Argentina, en cantidades muy pequeñas porque obviamente no hay suficiente. Pero más allá de eso, no sabemos de algún otro país que haya hecho igual que Takeda tiene cantidades muy limitadas, entonces no es que tampoco si un país está interesado en hacer un acuerdo bilateral con Takeda pueda tener cantidades importantes, al menos para este año. Entonces, eso con respecto a la incorporación en otros países. Y con respecto a, ¿cuál es la otra pregunta?
La posición de nuestra organización para
sí.
la vacunación para el personal en nuestras oficinas.
Sí, bueno, eso es algo interesante porque en realidad las recomendaciones que damos siempre son para los países, no necesariamente internamente, ¿verdad? Yo creo que ahí más bien, Gael, tenemos que ver eso nosotros porque pues es una vacuna, como les digo, que no es la vacuna que quisiéramos, no es la vacuna que tiene ese nivel balanceado de protección y tiene pues sus riesgos también. Entonces, creo que esa pregunta no la voy a responder en este momento, pero sí tenemos que tal vez darle un poquito más de análisis y sobre todo ver que un poco más de conclusiones de lo que está pasando en Brasil también, ¿verdad? Para ver todo esto de los riesgos de reacciones anafilácticas y la efectividad en el mundo real, ¿verdad? Ya cómo se comporta la vacuna protegiendo y todo eso. Pero por el momento creo que es una vacuna todavía, ¿verdad? Que no está en el nivel de madurez para tener ya más tranquilidad de recomendarla. Igual no va a significar por el nivel de protección que tiene, es relativo, ¿verdad? Un país, por ejemplo, que tiene más circulación de dengue tipo 1 y 2, que se aplique esta vacuna, no va a significar una mayor, ¿verdad? Protección que le confiera. Entonces, porque la vacuna justamente funciona muy bien, dengue 2 y dengue 1. Un país que tiene muy alta incidencia de estos, ¿para qué se va a aplicar la vacuna? Si sabe que más bien lo que va a proteger es muy poquito, ¿verdad? Entonces, hay varias cosas que considerar al respecto, pero creo que es una excelente pregunta que requiere un poquito más de análisis.
Yes, and if I may complement, because that's indeed a question that comes to us, and of course I turn to you for guidance. But what I would also add is, first, the vaccine is not available in all countries, so you cannot, you will be able to access the vaccine only if it's available commercially in the country, and we cannot, import vaccines
Exacto.
for personnel. Unfortunately, we have done that on a very exceptional basis during the COVID-19 pandemic, but those were really completely different and exceptional circumstances. So in this case, the vaccine first needs to be made available commercially to the population, so including you. That's the one. Second, the country itself, although it is recommended to follow the WHO or PAHO recommendations, makes its own regulations. So may authorize the vaccine only for children. In this case, we cannot go outside that age range. We've seen that certain countries have extended the age range up to 60. So here, I would say it's a discussion that you need to have with your own provider, because as Danielle has explained, there are benefits to these vaccines, although limited, but there are also risks that one should take into consideration. And you should balance the risk of getting these vaccines with the risk of getting dengue if, for example, you suffer from comorbidities. This is why the WHO position statement is so useful, because it recognizes that in certain situations, because you have those comorbidities, it may be more beneficial for you to get the vaccine than someone who is completely healthy. So to me, my recommendation is to have a discussion with your provider, if you happen to be in a country where the vaccine is available in your age range, to have a discussion with your medical provider to assess what is the risk and the benefit. And remember, this is only one component of the whole prevention package. And we know that other measures that Thais has presented, such as, removing the areas where the mosquito can breed, having mosquito nets, putting repellents, wearing long, maybe thick fabric now, contribute as well to your protection. It's the Swiss, model where the more layers you add, the less likely you have to get the infection. Thank you. So we are 4 minutes past this time, maybe one more question, and then we will look at the questions that were not answered and make sure that our presenters respond to them separately. Evelyn, do you want to choose? Yes.
The next question is from Alfonso. ¿Algún país inició estudios de fase 4 post-comercialización con las vacunas ofrecidas por el fondo rotatorio, tal como la OPS recomendó?
Sí,
Doctor Sales.
por el momento sabemos de Brasil, como lo mencioné antes en los Dorados, que tiene un estudio creo que con más de 100,000 personas, pero Takeda nos ha dicho que ellos también van a conducir otros estudios en otras regiones. Obviamente, esos estudios fase 4 son dirigidos por la compañía farmacéutica. Nosotros ahí no tenemos, ¿verdad?, una responsabilidad en lo absoluto, más que tal vez asesorar técnicamente algunas preguntas si fueran requeridas de los estudios fase 4 en sí. Pero en realidad esto, el leading es el manufacturer. Y sí, lo que puedo decir es que hasta el momento que tengamos conocimiento, Brasil. Sé que la vacuna también ya está en el sector privado en Indonesia y no sé si Tailandia, pero en el sector privado. Todavía no la han incorporado a nivel público. Y esos son datos que también, pues hemos preguntado a OMS si saben algo de reacciones anafilácticas y como no son masas altas en cantidades como Brasil, no tienen en realidad un reporte ahorita de esto.
Thank you, Daniel. And so I think we've come to the conclusion of this session. Well, thank you. It was very rich, very informative. I must say I learned a lot myself. So I want to thank all of our 3 expert presenters for their time and availability. Thank you very much. Very, very useful, very, very informative again, as I said. I also want to conclude to let you know that at the Health and Wellbeing Unit, we are here also to support you. Should you have any questions, if you're going to travel, if you have health-related questions, do not hesitate to contact us. Also, if you have suggestions for another topic to present, please send your suggestions to us. We'll be happy to look into them and then find the in-house experts. We have such a great pool here that we can use. Again, thank you very much. Thank you, Evelyn. Thank you in the background to Frederick, who coordinated this session. And take care, all of you. Bye-bye.
Bye.